a lot of patients will have back pain, but it hasn't been specified as to what kind of back pain it is. And if you actually look at the federal guidelines or CMS, the Centers for Medicare and Medicaid Services, sort of descriptions of different kind of back pain, they'll put them in these different buckets. So they'll say, okay, you can have back pain because of a spinal fracture. You could have it because of a spinal infection. You can have it because of various reasons, like a spondylolisthesis. And then there's this massive category of what's called non-specific back pain. And the fact that it's called non-specific tells you all you need to know about the level of intention that exists in our field behind this lion's share of patients. Non-specific, like there's no such thing as non-specific cancer, non-specific anything else.
Welcome back to the Spine Pod. I'm Courtney Schutze, and I'm here with my co-host Brady Riesgraf, and we are in sunny Naples, Florida. And Brady, we have been very busy.
We've been so busy. You know, we said we were going to have some exciting episodes in 2025.
We're
and in
delivering
season 2,
today.
yes, exactly. This is the epitome of that. You know, I think this one's really exciting. One, because we get to bring back someone who we've already had on the podcast, but two, someone who's a very close friend of ours. Today, we get to hear again from Dr. Ahilan Sivaganesan. And this time we're sitting down with him in Naples, Florida.
Yep.
Last time we were with him, he was up in Philadelphia with TJU. And now he's moved his practice down to Naples to build a spine practice with the Hospital for Special Surgery, HSS, with Naples Comprehensive Health, himself and his partner, Dr. Nick Clark. And we were so excited to be able to share this one. I think this is a really exciting one because it's kind of a two-parter. It's a little bit different. We get to talk through the patient journey and what it's like finding care and how you go about finding care, because we know that can be difficult. And then in the second part, we actually get to dive in and look at some images, look through MRIs, because when you go get imaging, you get a radiology report, and there can be some confusing language on there when you're trying to navigate where you go to get care, what the next step is. And we try and clarify some of that with Dr. Siva today.
I agree. It can be scary when you get those reports before, and you go look at them before you have your appointment with your doctor, your surgeon. And I'm definitely guilty of going to Dr. Google and trying to look stuff up and then getting even more scared. So in this episode, Siva, we talk about that patient journey, how sometimes it can be extremely frustrating to be a back pain patient. And a lot of times you can feel like I don't have any options, or I was only given fusion as an option and I don't want to do that. What do I do next? And Siva talks to us about what that experience is like, some potential ways to have conversations with whoever your practitioner is, and also how to kind of alleviate some of that fear around these images, which I think is so helpful for patients in this episode. And I'm really excited to have him back on. We followed him across the country because he's absolutely worth it. He's a phenomenal human, an amazing surgeon, and he has so much knowledge to share. And I feel honored we get to do it again.
Absolutely. Dr. Siva is an abundance of knowledge, but he's also got this down-to-earth humbleness to him. And so he resonates with a lot of what we believe in, right? Restoring function, restoring motion preservation. And so we got to have this sit down, and then we actually got to do a hard hat walkthrough for the new HSS and NCH collaboration for the surgery center that they're building. And incredible. I mean, this place is going to be immaculate. So for him and Dr. Clark to be able to be part of that, I think is so special. And we're really excited to share this one.
Yeah, absolutely. So enjoy this episode with Dr. Ahilan Sivaganesan.
came and joined us for round 2. You must have liked round 1 if you're going back for round 2.
Here we are.
We followed you across the country for round 2. How about that?
A little bit of a different setting now.
Yeah.
You know, not exactly downtown Philadelphia, but I hope you guys are enjoying your stay down here.
Absolutely. I don't think we could be happier to be anywhere else. Dr. Ahilan Sivaganesan, obviously everybody who has watched our show has seen you before. So we are very fortunate that you take the time again to come sit down with us. Truthfully, a big reason that we want to come sit down with you was because we had so many positive reviews and so many people on the concepts that you talk about, right? Health economics, and truthfully, a lot of the problem points that we're seeing, not just in healthcare, but in spine specifically. And I think you're a surgeon who's trying to solve some of these really, really complex problems. Obviously, being down here in Naples is nice.
Yeah.
Being right down on the beach. You know, tell us, because you came down from TJU up in Philadelphia and you moved down here. Practices are very, very different. Can you tell us a little bit about that, just to set the stage on, you know, what that transition has been like coming down here?
Yeah. What have you been up to?
Yeah. Well, first of all, to both of you, Courtney and Brady, thanks for having me back. I'm super excited. But yeah, I think a lot has changed since the first episode that we did. So I've been here in Naples for about 3 months now. And it's like night and day compared to sort of my professional reality at Thomas Jefferson. In a lot of ways, you know, Thomas Jefferson, I was in an academic neurosurgery department in a major urban quaternary medical center. And, you know, it was an amazing place. The kind of surgeries I was doing and the kind of patients I was taking care of very much represented, I guess I would say, is sort of a traditional, mature surgical practice in a major metropolitan area. And by mature, what I mean, I guess, is that a lot of the workflows and protocols for how patients got in the door to see us were very kind of set in stone by, you know, previous generations of doctors and surgeons. And now I'm down here in Naples, Florida, with the Hospital for Special Surgery at NCH, which is Naples Comprehensive Health. And we're starting a program from scratch. And I know we touched on this in the last episode. And now, you know, I'm sort of knee deep in it. And there are a lot of things that have surprised me. And I'm excited to sort of talk about some of that with you guys, both in terms of just the demographics of the patients we're taking care of, obviously this beautiful environment we're in, but also sort of what it feels like to take care of patients on the front lines when you aren't in this sort of very mature practice environment that has been sort of established well before you got there.
Can you talk about, let's set the stage. Talk about what you're talking about there. So you're talking about 2 different ends of the spectrum, right?
Right.
One is essentially a surgical patient that is ready to go and their next step is surgery.
Right.
Now you're talking about being on the very front end of that, where you're seeing patients where truthfully they're still trying to figure out where they need to go next.
Yes.
Can you delineate those 2 for us and for everybody listening?
Yeah. So to give you a sense of what happens in a lot of, you know, mature practices is that if a patient calls in with chronic back pain, what ends up happening is that there's some version of a call center that is going to determine who the right person is for you to see, especially if you're not saying, well, I want to go see Dr. Siva. If you just say, hey, I know I've got a problem. I would like your institution or your practice to help. And they have certain decision trees and they vary a lot from practice to practice to sort of say, hey, you know what? You should probably get in to see a physiatrist first. Or, you know what? We want to have you see our non-operative sports medicine doctor first. And then those providers will kind of work you up. And then if they decide at some point that you are a surgical candidate, they'll send you off to see the surgeon. Some version of that is like the reality for the lion's share of practices out there. And for better or for worse, when I got down here, both my partner, Nick Clark, and I, for both of us, these protocols didn't exist, right? And we're new in town. So we also want to have as much of an open door as possible, get the word out that we're here. So we're basically seeing anyone and everyone that has a spine complaint or problem. And what that meant is that very quickly, within my second week of seeing patients here, I was really surprised by how many patients I was seeing with chronic low back pain, for example, that didn't have the quote unquote traditional workup. So that maybe they had x-rays, maybe they didn't even have any imaging, and they were coming to us to get some guidance. And understandably, most of them aren't necessarily that interested in surgery. They just want answers. And truthfully, when we first started encountering this, my reflexive knee-jerk reaction was, oh, well, I guess this is part of the growing pains of starting a new program, is that you see patients that otherwise might have been sent elsewhere. And funny enough, most surgeons will tend to like grade their own practice by the percentage of patients that they're seeing in clinic that are eligible for certain classical spine surgery solutions, right? Because they want the hit rate in their clinic to be really high. And if you're seeing patients that have chronic low back pain with quote unquote minimal workup, your so-called hit rate is going to be low. And so initially I was a little bit sort of like, all right, let's get kind of mentally braced for this initial phase. And then eventually things will mature and our protocols will be set in place. But I have to say, probably the biggest surprise since I got down here is that I actually found myself really drawn to these patients at this quote, early time point in care, and found myself really wanting to understand their problems and be of value to them much more upstream than surgeons traditionally come into the mix. And so there's probably a good amount to unpack there, but that's sort of the biggest sort of like initial surprise that I felt coming down here.
There's definitely a ton to unpack there. I already have like so many questions that I want to ask. But the first one I want to just touch on, because I want to talk about this type of specific patient. But first, I want to just talk about the experience of being a spine patient, kind of just a patient in healthcare overall. And we talked about this in your first episode too,
Yeah.
kind of that AI image of like what it's like to go through the care continuum. But it can be so frustrating of like, I don't know where I'm supposed to go first. What does that even look like? So it makes sense to me that patients would end up seeing you just because they're like, I have back pain and I don't know what else to do. Can you kind of explain the conversation that you have with those patients that are confused, that end up at your door, that they're just like, I have back pain and I don't know what to do? Like, what does that look like when they talk to you?
Yeah, thanks for the question. So a lot of patients, they have been dealing with this for a long time. It's like that nagging low back pain that sometimes is so severe that it's stopping them from working or taking care of their grandchildren or whatnot. Sometimes it's just bad enough to affect your like mental health and your self-esteem and your ability to be a normal family member and part of society, but not so bad that, you're stopping everything you're doing. It's like in that middle zone. But either way, the lion's share of these patients are so frustrated because they feel like they've been to every type of expert, right? They've done 3 rounds of physical therapy at 3 different physical therapy offices because the first one didn't work. Then like, well, maybe it's the physical therapist. So let me try a different office. Then they'll go to a surgeon. The surgeon will say, why are you in my office? These are the kind of patients I treat. I don't know how you got in here. And then after the patient leaves, the surgeon will complain to the practice manager, like, who let this patient onto my schedule? Because, I can't really do much for this person. And then they'll go to pain doctor, and the pain doctors will either try medications, injections. Nowadays, they'll even try certain implant-based procedures, sometimes fusions, for these chronic back patients that, haven't found a home essentially. I've used this analogy before, but the way it seems to me is like, if you're traveling abroad, say you're in Taiwan with your family and you go to one of these street markets and, there'll be lines and lines of folks selling different pieces of crafts work or souvenirs. And you're maybe trying to get to some cool destination that's, but you have to walk through the street market to get there. Every step along this way, somebody's trying to peddle some type of good to you, right? Like, hey, buy some of these trinkets or buy some of these necklaces. You're just trying to get to your destination. I don't want to sound too cynical, but that is how so many chronic back pain patients feel, is that every type of expert that they go to is essentially asking themselves the question, which of my tools in my tool belt can I apply to this patient, right? And so the pain doc is thinking about which medications, which injections, which non-surgical procedures can I do for this patient? The surgeon is thinking, which of my surgical procedures can I do? And if not, I can't help you, get out of here. And then the same thing with the physiatrist and everyone else. And this has been a sort of realization of mine, is that most providers naturally, it's just human nature, ask themselves the question, which of my tricks will work in this situation? And very few providers are sort of taking that 30,000 foot view and saying, what is the root cause problem of this patient's back pain? And if I don't have the answer quite yet, how can I build a case with some thoughtful tests and workup for what the root cause is, and then design a care plan for that? And sometimes that involves surgery and sometimes it doesn't. But everyone's it sort of has their blinders on and has tunnel vision. And chronic back pain patients are suffering because of it.
I'm sure there are so many patients listening right now saying, you are speaking directly to me. That's exactly how I feel. That is a super frustrating experience.
Right. Yeah. It's funny. Like when I was at Thomas Jefferson and now here at the HSS Naples program, my initial instinct was to put a lot of my mental energy into the idea of how can we build a next generation comprehensive spine institute where every expertise, every sort of angle that you can take on a patient with back pain, that we're going to have it covered, like a one-stop shop, right? And that is an ideal goal, I think, and it's something I think we'll get to here. But a big realization I had is that, it's kind of cliche to say that, if you want to change the world, start with yourself. The question I sort of ask myself is, how can I embody a comprehensive spine institute within myself first? How can I provide that thoughtful, functional, non-surgical assessment piece? How can I then steer the patient through various non-surgical options? And if surgery is required, do that. Like if I can embody that from all angles myself, that's the first step in sort of building that into a program. And it's a unique opportunity for us to do that here because we don't have that super mature practice yet. So we can make this what we want it to be. And so that is like one of my sort of newer passions. And I think it's a natural sort of evolution from sort of the value-based care work that we talked about in the last episode. Because these chronic low back patients, it's like they don't have a home right now. And so that's sort of where I'm coming out with that.
So I think that's a really important skill. I'd like you to go back to that. So you talked about this knee-jerk reaction that you had when you first came here. I think this is a global trait, right? This is not a surgical trait that, I need to change how I emotionally react to this thing that makes me feel a certain way, right?
Yeah.
And so you've only been down here 3 months.
Yeah.
I'd like to hear how you went about that, or what made you change that mindset from that same patient still walking in the door right now, right? That patient that's on the early side of the continuum where 3 months ago, your knee-jerk reaction was like you see a lot in industry, which is, why is this person in here? They're not ready for, it's not that you don't want to help them. They're not ready for the services that I'm ready to provide. To where you are now, which is, how do we find the right services for this person or the right continuum for this person? Because I think that's a big leap,
right?
Especially in 3 months. I'd love to hear how you went about changing that dynamic.
Yeah, no, thanks for the question. So there's two basic sort of realizations I had. One is that there are more things that we as surgeons can do for these low back pain patients than I initially sort of really appreciated when my first couple years of practice. And a lot of that has to do with endoscopy, which we'll talk about more. And the second piece was that I made a point to myself to become as well studied and nuanced in my understanding of chronic low back pain in a way that I think surgical training does not capture. So I'll give you a classic example of this. What did I do for 95% of the patients that were coming to me with low back pain and either just x-rays or they had an MRI that didn't really show much? I was sending them to physical therapy, right? The patients, the really sophisticated ones, will ask, well, what do you want me to do in particular in physical therapy? And I would sort of like politely shrug my shoulders and say, well, it's going to say lumbar PT on the prescription and the experts will take it from there, right? But there's as much difference from one physical therapist to the next as there is from one surgeon to the next, right? And it's not very confidence inspiring when the specialist that you're going to see just says, I'm going to give you a script and they'll figure it out, right? So I was doing this over and over again. Lumbar PT. It's like this black box for most spine surgeons. So I started really studying intently about like different schools of thought for physical therapy, different like modalities. And I realized that a lot of the advice that we give patients, either through physical therapy or just in general, is oftentimes just based in dogma or what our mentor might have said at one point in passing to a clinic when we were in training. And I'll give you a classic example, is that everyone thinks that muscle flexibility is really important for combating chronic low back pain. And a lot of that is because there is something called a neurological stress reflex, that if you bring your knees up to your chest, or if you are standing and you reach down to touch your toes and you do that 5 times, for about 20 minutes, your low back will loosen up and you'll feel a little better. But that has nothing to do with the biomechanics of your spine or the paraspinal muscles. It's just literally a neurological stress reflex. But what you're actually doing is you're loading your discs when you do that. And if any component of your back pain is discogenic or coming from the intervertebral discs, doing that over and over again is actually going to accelerate your discogenic back pain. And this is something that is just so deeply entrenched in sort of the zeitgeist, right? Like flexibility, yoga, things like that are great for your back. And I'm not saying like I'm a huge proponent of yoga in general, but a lot of these things that we just say reflexively, it doesn't really hold muster when you talk to people who are spent their entire lives working on patients with back pain through physical therapy. So that's just one small example. The other example I'll give you is that, people talk about range of motion and muscle flexibility as this great panacea, right? And that's true for most joints in your body. So if it's the muscles around your hip or the muscles around your knee, range of motion and flexibility is great because those muscles are designed to promote movement. But when it comes to the muscles around your spine, the muscles around your spine are actually there to stop movement and to provide stability for your spine. And like the classic analogy that expert physical therapists will talk about is that if you had a stack of oranges and you put a 10-pound weight on the top of those oranges, the entire thing is going to collapse, right? So what if instead you put a bunch of toothpicks into the stack of oranges and then you put string into those toothpicks and tied them to the ground? Those strings that are holding that stack of oranges up and tied to the ground, those are your paraspinal muscles and your core muscles. And because it provides that stability and robustness to the stack of oranges, you can put weight on top of that stack now and it's going to stay there. That's what our paraspinal muscles and our core muscles do. So if you spend your entire physical therapy program trying to increase a range of motion, but you're not working on the muscle endurance that is required to be able to stiffen those muscles and offload the spine, you're going to accelerate your back problems and let alone, not have like a short-term relief. And so these are all these sort of dogmatic things that, we as surgeons sometimes are not like the most well-versed in, but the patients, they're looking to us for answers. Like we're for better or worse, for us, we're like the first stop for them. And so those are just 2 examples of things that, like, as I started reading more and studying more about these things so that I could be a better coach or like advisor to these patients, it made me realize how much of a gap there is in surgeons' understanding of these functional realities that deal with the muscles around the spine.
I think it just speaks to the silos that exist so strongly.
Yeah.
We had Dr. Bodner on a couple episodes ago talking about hip spine and the connection there and the big, how that's going to open up things for us as we start to look at ourselves as a kinetic chain,
Yes.
right? But the same thing goes from what you're saying, just for a patient dealing with spine of who is the provider or the clinician
Right.
leading up to. And that silo really is unfair to our patients, I feel like.
I totally agree. I'll give you another example, which is that a lot of patients will have back pain, but it hasn't been specified as to what kind of back pain it is. And if you actually look at the federal guidelines or CMS, the Centers for Medicare and Medicaid Services, sort of descriptions of different kind of back pain, they'll put them in these different buckets. So they'll say, okay, you can have back pain because of a spinal fracture. You could have it because of a spinal infection. You can have it because of various reasons, like a spondylolisthesis. And then there's this massive category of what's called non-specific back pain. And the fact that it's called non-specific tells you all you need to know about the level of intention that exists in our field behind this lion's share of patients. Non-specific, like there's no such thing as non-specific cancer, non-specific anything else. And so the vast majority of patients get put into this category. But if you spend the time talking to the patient and understanding, okay, what are the triggers of your pain? What are the things that make you feel better? What daily activities are you avoiding now because it's making your pain worse? Just based on that history taking, the thoughtful history taking, you can start to winnow down the potential sources of that back pain. Then you have to do a really thoughtful physical exam. And it's not just when the patient's like sitting on the table. You have to get them to walk. You have to get them to do various types of motions. And then with the physical exam, you can start narrowing down the differential of the different causes of the back pain. And then something like an MRI is like a confirmatory test. It's not you don't make a diagnosis based on the MRI. It just confirms the hunch that you have based on the history and the physical. So if you do that, just based on the history and the physical alone, a fair number of patients will have what we call discogenic back pain, as in that the intervertebral disc is the source of the pain. If you get an MRI, sometimes it's as clear as day that one disc is really black, dried out, and collapsed, and all the other discs are nice and plump and filled with fluid, right? And that can be a clue that, okay, maybe that disc is a problem. But what's been the traditional solution from the surgeon standpoint? To do a fusion, right? And if they're more innovative, maybe they think about a lumbar disc replacement. Even that, though, is a pretty large surgery. It's not low risk to go in through the abdomen. Right. And that surgery has to go really well in the hands of a surgeon that has done this, thousands of times. But there is, for example, a much less invasive procedure, an endoscopic discectomy, which can be a great solution for some of these patients. What you end up doing is, once you have a hunch that the disc is the problem based on the history and the physical, and perhaps seeing a tear in the outer lining of the disc on the MRI, something called an annular tear, what you do then is you take the patient to the procedure suite and you can do a discogram. So you basically inject dye into that disc with the patient awake. And if they tell you that you're reproducing the very exact pain that they have in their daily life, it's like the ultimate confirmatory test that that's the source of the pain. And you can see the contrast dye leak out of the disc through the tear in the outer lining. Okay.
Which also is affirming for you.
Yes.
That,
even more confirmation. It's like radiographic confirmation and symptom confirmation from the patient. So that happens instead of doing a huge surgery in these particular patients. You can go in with an endoscope and you can basically debride the dead fragmented tissue in the inside of the disc. And oftentimes you can even seal the hole that is causing a leak. And for the right patient, this can do wonders for their discogenic back pain. And this is something that is not that popular in the surgical community, partly because surgeons aren't looking to take care of these patients. And two, endoscopy is still not that widely adopted. And there are a few examples like this where endoscopy can provide an outpatient percutaneous solution for well-selected patients with a certain type of back pain. And but you got to know what you're looking for, and you got to know what options exist.
Can you talk about that? So we're on a really good path right here. So we just talked about discogenic back pain. Let's talk about some of the other functions of back pain, right?
Yeah.
So you can have vertebrogenic back pain or
Yes.
facetogenic back pain. So for patients that don't fall into that first category,
Yes.
let's talk about those problems.
That's great. So in general, in this sort of non-specific back pain that we're trying to shed light on, discogenic is one. And as you guys know, three spine is called three spine because there's three primary joints in every motion segment. There's the disc, infravertebral disc in the front, and there's what's called the facet joints in the back bilaterally. The facet joint can also be a source of pain. We call that facetogenic or facet-mediated pain. And just based on the history alone, if the patient says, hey, look, whenever I extend my back, whenever I torque my back or twist my back, or like a golf swing, for example, that's what really gets my back pain flared up. That's a clue that it could be facet-mediated. An MRI will often show a lot of arthritis and fluid in the facet joints, which can also be a clue that the facet joint is the main driver of the pain. So what happens to these patients typically? if a provider is sort of clued in enough to sort of have this hunch, they'll send the patient to get what's called like a medial branch block. It's basically an injection in the facet joint to try and desensitize it and see if it helps with the back pain. It's usually temporary. And so what patients end up then going for oftentimes is what's called an ablation or a radio frequency ablation, where basically a pain doctor will go in and take a radio frequency probe and basically try to deaden the nerve that is providing sensation for the facet joint, which is not a bad solution at all. But this is also something where endoscopy has provided a new opportunity, where if you're convinced that the facet joint, say the right L4-5 facet joint, is the main driver of a patient's right-sided back pain, what you can do is you can go in percutaneously with an endoscope. So you have direct visualization. You can find the medial branch nerve, which provides sensation for that joint, and you can snip the nerve. So now you have a much more durable, long-term solution for that facet-mediated pain than sort of blindly burning the neighborhood around that nerve with X-ray guidance. And there's a lot of evidence now that the durability and the effectiveness of endoscopic, what's called medial branch transection, is superior to the typical ablation for facet-mediated pain. So now we have discogenic back pain, which for some patients can lead to this endoscopic discectomy. You have facet-mediated pain, which for an appropriately selected patient, you can do this endoscopic medial branch transection. That's two big buckets out of this non-specific back pain. And I think, the other big bucket, is typically called like muscular or musculoskeletal back pain, because it'll get sort of described as like muscle strain or muscle stiffness. A lot of that has to do with, to the point of the hip spine episode, hip asymmetry, hip stiffness, posterior chain muscle tightness, all these things that require more of a full body assessment, right? And so that requires a very thoughtful physical examination, and it requires the physician or the surgeon to zoom out a little bit and not just look at the MRI for a clue as to what's going on, but to evaluate the full kinetic reality of the patient and then move into what the treatment might be. So I hope that helps a little bit with some of the broad topics of back pain.
Absolutely. I think it's fascinating. I just think, we talk about this generalized back pain, right? And it's really easy to say, okay, well, we've got these patients and we want to run through them. And we talk about discogenic back pain. And then the patient says, well, if I don't fit into that, then where do I fit? Right? Because that's one of the problems we're trying to solve is, where do I fit into this continuum? So for patients that are coming in, you fall in this generalized bracket. You look at an MRI report or a CT or an X-ray. Are there general pathologies that you see on there or descriptions that you see that would fall into that generalized, or are those pathologies that you wouldn't see on imaging?
That's a great question. Thanks for bringing up the MRI. I think the thing that can be the most stressful for patients and also sometimes frustrating for doctors and surgeons is this trap that we all fall into, where we assume that the description of the imaging on the MRI report is your diagnosis, right? That's our tendency. You read something, especially you've been anxiously awaiting the results of your MRI. You finally get the report. Yeah. You log into your online portal, you print it out, and you're like, okay, what do I have, right? That's like the feeling we all get. And you might see something like annular tear. That's the tear in the outer lining of that disc, right? Or you'll see foraminal stenosis, or that sounds bad, right? Like, what does that mean? And the first message I probably want to get out there is that these are imaging findings, but imaging findings do not equal a diagnosis. And so what you need, the diagnosis comes from listening to the patient's symptoms and getting a physical exam, and then using the MRI as a confirmatory test. And so if you see an annular tear on the MRI and you have signs and symptoms of just discogenic back pain, and the provocative discography test confirms it, then you have a diagnosis of discogenic back pain, right? The annular tear finding on the MRI is not the diagnosis. And similarly, you can have an arthritic facet on the MRI. Like the read might say severe facet spondylosis, which just means severe arthritis. That doesn't mean that that is the source of your back pain. It has to match with the description of the pain patterns and what brings on the pain, what makes it better, and the physical exam. And then you take the MRI and say, you know what, that corroborates what we've already been thinking. And then if you do a diagnostic injection in that facet joint and you get some temporary relief, now you're onto something. So it's really like this like deductive reasoning sort of mentality you have to have. But if you're a provider who's sort of just naturally sort of thinking, oh, okay, like these are the things that I can offer. Do I see any evidence that, you know, in the imaging or in the chart to support the case for one of the things that I can offer? Then you might miss the boat. And it's not any provider's fault. That's kind of how we're trained. It's like how all our mentors sort of went about businesses, right? Like these are my tricks. How can I deploy my tricks? As opposed to starting with the patient first and saying, what do we think the root cause is? And what is like the sequence of steps we can take the patient through to get confidence in the diagnosis and then work up a treatment protocol that starts with the least invasive thing first and then goes from there.
So this is such a good topic. I absolutely love this. I think this is so important for patients because you see both sides of the spectrum, right? You have patients that will call in or come in and say, my x-rays are terrible, therefore I need something done.
Yeah.
And the truth of the matter is some of those patients are asymptomatic,
Yep.
right?
Totally.
Which is kind of crazy, right?
Totally.
But then you see the other side of the spectrum where, you know, your x-rays are clear, your MRI is clear, but someone will come in and say, I have a 9 out of 10 back pain.
Yeah.
We can't just usher that person out the door because you don't find anything on imaging, right?
Right.
And so you hit on a really important topic here, and that's the care continuum, right? And I think that's really important. I think that's one of the reasons that we talked a lot about endoscopic care. We love it because it's a great kind of first step into that care continuum. And as you look at it, you can utilize that as a first step into the care continuum. Can you talk about that? So we've talked about a couple of different technologies. You talked about disc replacement. You've talked about MODIS, lumbar total joint replacement, and endoscopic care. Can you talk about, you know, as we wrap here, what that's like and how that changes the care continuum, having different options like that?
No, thanks. You know, I think the most frustrating sort of story for a patient with back pain that I can think of that's far too common is the patient that, like, nobody wants a fusion, right? Like, if you know nothing else about healthcare and you're just a patient, everyone knows to avoid a back fusion if at all possible. But then there are these patients that are so frustrated and so like at a loss for what to do next, and they feel like they've tried everything, that they're like, well, if my choice is between living with this and doing something about it, and if the doing something about it equals a fusion, maybe it's time to bite the bullet. So many patients are in that category. And the message I would love to convey in this conversation is that does not necessarily have to be the case. And the alternative doesn't even have to be another implant-based procedure necessarily, like a lumbar disc replacement. It could be an endoscopic procedure, or it could just be having someone with a fresh perspective, taking a look at your situation from scratch and trying to get to the root cause of it. So to that end, we always think about physical therapy and medications as being the most conservative thing you could do for a patient. The next step is injections, and the next step is some sort of intervention or surgery. And where I think endoscopy is thriving and will continue to thrive is in this gray zone between injections and traditional surgery. Because if you think about it, and we'll see this in the cadaver lab, what is the first step we do when we do an endoscopic procedure is we insert a spinal needle into the area of the spine that we are targeting. That is also the very first step in doing an injection, right? And so even in the procedural nature of endoscopy, you can see that it is a natural extension of an injection, right? And so I really, when I talk to patients and I say, hey, you know what, you might be a candidate for this medial branch transection because we think your right L4-5 facet is a huge driver of your facet-mediated back pain. And they say, well, what is that about? How do I sort of make sense of this? I really explain it to them as, you've had an injection before. We're trying to avoid big morbid surgery. This lives in the in-between. And I think that has been a big void for patients who are disabled enough to not be able to say this is their new normal, but maybe not so disabled that they're ready for a fusion, which probably is not going to work anyway for this kind of problem. And that's where endoscopy, I think, will thrive. And I really see endoscopy as a motion preservation strategy. It's not just a way to do the same type of surgery with smaller tools and smaller incisions. It is a way to take certain patients that either had no good solution or only fusion as a solution, and offer them something that doesn't involve putting implants in, but that can address the root cause of their pain while preserving motion. And I think that seeing it as a platform for motion preservation, I think opens up a lot of avenues for solutions for a lot of patients.
I think we say crawl, walk, run. And I think the way we're set up is you crawl with, conservative care, and then you have to run if you go straight to a fusion. And I like this idea of like that walk with endoscopy and these options you're talking about of you might end up in a place where you need a full on, device surgery, right?
Yes.
But this could be an in-between to either give you some time or it could fix it for you. And the risk and like how big of a procedure and how long you're out from your life is so much smaller, which I think is so exciting.
Yes.
Especially when you start thinking about things like Modus that could potentially be on the market.
Absolutely.
Giving a patient some more time to keep them in motion and not just locking them down with the fusion.
Absolutely.
To let innovation have some more time to move forward.
No, I think it is so true. I mean, there are certain types of endoscopic procedures where you're doing the same type of fundamental procedure on the spine just with less collateral damage. That is a part of endoscopy, that's great. That's a step forward. We all want to be able to, get the job done with less invasiveness, and endoscopy represents that for many situations. But there are specific situations where endoscopy enables the ability to take care of the problem in a fundamentally different way, in a fundamentally less destructive way to the spine that allows you to address the offending culprit in the spine, whether it's a disc herniation, a bone spur, what have you, and fundamentally destabilize the spine less and thereby be able to avoid a fusion. And I've done a few of those procedures in Thomas Jefferson. We've done more of them down here in our short early experience here in Naples. And those are some of the most satisfying patients to take care of. Will they need something else down the line? Potentially. But being able to offer something where they really thought it's live with it or fusion, and you can come and offer a third way, patients are so excited for that opportunity. And I know we'll have a chance later. I'm excited to show some MRIs as examples of patients who normally might fall into this sort of desperate situation where they're between a rock and a hard place, and where endoscopy can provide a third way and some real relief.
What provides a walk before you can run, it also provides motion preserving options, right?
Yeah.
And that's why we get really excited. That's how we initially got put together. And it's funny, you talk about annular tears, and someone we know very well, Dr. Kim, he also is a big annular tear and treating it with endoscopic care, right?
Absolutely.
But
the world is small when you start,
Yes.
So shout out to him, but it preserves your options on the backside. What I'm really excited about, this is a unique episode, right? So we're talking about some of these things, and our next step is we're going to actually jump in and look through some of these reports. So we're going to show patients what it actually looks like, right? What you're looking for, what these cases look like, and kind of take some of the scariness out of reading through those reports, right? Because when you get it, it is tough to sift through that. It's tough to sift through the information, especially when you're looking for the next step. And so it'll be exciting that we'll take our next step out of here, out of sitting down and being able to actually walk through some MRI reports and X-ray reports.
I'm excited about that. Like, I feel deeply at my core that I am a spine physician who happens to be a very good surgeon. Not, I'm a spine surgeon. If I can help you with my tricks, that's great. If not, good luck. And so to that end, the opportunity to sort of, de-stress and clarify the meaning of some of these, hard to make sense of words and terminology and MRI reports, and even give a couple examples of, here's a situation where, 8 out of 10 surgeons might recommend X, but you should at least know about Y and ask about it before jumping in head first. I think is a great opportunity. And thanks to you guys for providing the platform for it.
Absolutely. Well, let's jump right into it, and let's jump into the next session and look at some X-rays.
All right.
I think this is really exciting for everybody to be able to go through and actually look through some X-rays and some MRIs, and to look through, everything that you see on a radiology report, right? Because it can be a little scary, it can be a little daunting. So to be able to, obviously we talked about a lot of different topics in the first part, right? We talked about this chronic back pain problem, this long-term generalized pain, but there's a lot of ways that, one, you can treat those things and still preserve motion. So I'd like to go through those. I don't think of a better guy to do that. So we're excited to be able to go through that with you, Dr. Sivaganesan.
Yeah.
So let's jump in, and I want you to kind of walk through and kind of show what you're seeing on the screen here and how you can go about treating some of those things as well.
Yeah. What have you prepared for us
Yeah,
today?
that's right,
I'm so
that's
excited.
right.
I got my laptop out.
I know,
you know?
it's multimedia. No, so thanks for this opportunity. So I think there's two things that would be great to sort of convey in this portion. One is just to demystify some of the terminology that people will see in the reports for their lumbar MRI imaging. And the reason for that is that I can't tell you how many times patients come to our office and every spine surgeon's office, and they've been sort of perseverating and getting fixated on certain keywords and buzz phrases in the report. And you might Google it, and you might not get a very reassuring result back from your research, and you're sort of waiting with bated breath to hear the spine surgeon sort of explain to you what these things mean. And if one thing we can do in this venue is sort of peel back the curtain a little bit and just give you a sense for what some of these terms mean, I think that could be helpful in just reducing the anxiety level and reducing the temperature level a little bit for patients that are trying to figure out what's going on in their back. And then the second thing as part of that also is to provide some representative examples of patients that may get told by a lot of spine surgeons that they need a fusion operation or that there's nothing to do, when in fact there is a non-fusion motion preserving strategy available. And they say pictures better than pictures worth 1,000 words. So let's see if we can put that to the test here.
Amazing.
So to start out with, what we have on the screen here is what's called a sagittal view of a lumbar MRI. So just for a 30,000 foot view here, when we look at an MRI of the lumbar spine, we're really looking mostly for what's happening with the nerves and the soft tissue in the lumbar spine, as opposed to a CAT scan, which is best for looking at the bony architecture of the spine. And when it comes to the nerves and the soft tissue, we tend to look at the spine from two dimensions. One is what's a side view or a sagittal view, and the other one is a cross-sectional view or an axial view. And so if you hear the word sagittal in either that a doctor mentions or you read that in a report, that just refers to the view that is being taken to look at a part of the spine. So here on the screen, we have three versions of a sagittal view of an MRI of one patient. So all three panels here are from the same patient. And I'll just take you through some of the basic building blocks of the spine that we see, and then I'll start going into some of the pathologies that we end up encountering. What we see here are three panes. It's actually the same image, just in three different views. All the sagittal view where you're looking at the spine from the side. So just to get your bearings, I'm going to annotate a little bit to give you an idea what some of the basic building blocks are. So if you see this square-like structure right here, that is a vertebral body. So that is the basic bony building block of the spine. Above that, if you see this black rectangle, that is an intervertebral disc. That's the sort of suspension, sort of cushion, sponge-like substance that is one of the key joints in every motion segment of the spine. The white substance you see here running up and down, that's spinal fluid in what's called the canal, the center part of the spine. This black gray substance here, those are actually the individual spinal nerves running through that central spinal canal. And then these substances right here, if you were to feel the middle of your back and you feel those bony protuberances, those are the spinous processes. And that's actually what you're seeing on the right part of each of these panes. So what we're seeing here is the vertebral bodies, intervertebral discs, the spinal canal with nerves and spinal fluid, and then the spinous processes off to the right. And so one thing you might notice on these views is that you see a couple discs, this one right here and this one right here, that have a lot of white signal, sort of bright signal. That represents water content. And as you can imagine, a healthy disc is a plump and fluid water-filled disc, because that means it's not dried out. It has a lot of ability to compress and expand and basically absorb shocks. And that's in contrast to the disc we see here at L45, which is much more dark and black. And what that means is that disc has started to degenerate. it's lost some of its water content. That can sometimes be an indication that discogenic back pain is coming from that disc. It's not sufficient to say, oh, that disc doesn't look right. Obviously, that's the source of your pain. We need to do something about it. That's not what I want the message to be. But when you see something like that, it could be a clue in conjunction with the history and the physical and everything else, that could be a source of pain.
Mm.
And then what I'd like to draw your attention to now is, if you notice, and it's easier to see on the right-sided pane, there's an arrow here, this little bright white dot. That is what we call a high intensity zone. And what that often reflects is what's called an annular tear. And so what does that mean? That's a term that is also often mentioned in radiology reports. The intervertebral disc is basically made of two components. You can think of it like an orange. There's a tough outer rind called the annulus fibrosus, and there's a soft jelly-like center called the nucleus pulposus. And so if you get a tear in that outer rind, some of the inner soft fruit jelly-like substances can start to leak out. And that when that annulus has a tear, we call it an annular fissure or an annular tear. And this high intensity zone can be a clue that you have an annular tear. So if you're a patient that has been suffering from back pain for a long time, let's say that back pain is worse when you sit for long periods of time, when you cough, or when you bear down, these could be signs that it's discogenic in nature. And then if your MRI is suggestive of one particular disc that is much different than all the others, much darker, blacker, perhaps collapsed, and it has this high intensity zone that's suggestive of an annular tear, that could be a major contributor to your discogenic back pain. And this is exactly the kind of patient that we might suggest doing a discography study on, to inject some dye and to see if we can provoke that classic pain the patient is having, see if that contrast dye is leaking out of that tear in the outer rind. And if so, there's an endoscopic discectomy that we can do to help address that type of pain for that patient.
So I think that's a great place. You know, you just use a lot of big words, annular tear. So I'm scared, right? But then it seems like your options are pretty simple. It doesn't have to be this big, scary thing. There are many options before we're going to say like, oh, you have to get a fusion because annular tear sounds big to me.
Right.
So for a patient, they see this on the MRI. Just if you can reiterate the importance of like, that does not mean that worst case scenario is coming.
Thanks for bringing that up. I think perhaps the most important thing here is to differentiate imaging findings from diagnosis, like we were talking about before. A patient can have a diagnosis of discogenic back pain. That's something you can hang your hat on. An annular tear in and of itself does not mean that it's the cause of your pain. It does not mean that you need surgery. So I don't want patients to think, oh my gosh, annular tear sounds like the worst thing in the world. Who wants a tear in their annulus? Oh my gosh, I must now be a candidate for something major because this is a serious problem. I wouldn't think of it that way at all. In fact, most annular tears are asymptomatic, meaning most annular tears do not cause back pain. And so for every patient that we see where there's an annular tear that we are able to match up with back pain, there's probably 5 or 6 patients out there with an annular tear in the MRI that don't even know about it. And so this is only relevant when it comes to a procedure or physical therapy or anything else, when it's a confirmatory test for a diagnosis of discogenic back pain in the first place. So if you have back pain, but it's not discogenic, and you happen to have an annular tear, doing a procedure for that, whether it's endoscopic or a fusion, is not going to help with your back pain. And this is part of the reason why back surgery has had a bad reputation in the past, is that patients, providers, surgeons, everyone kind of fall into this trap sometimes and thinking, well, that doesn't look right on the picture. We got to make that right. What are our tools? Either fusion, disc replacement, or what have you. You do it, technically perfect job, but it was the right surgery, or the right surgery done for the wrong reason is not going to lead to a good outcome. And so if no other message is conveyed except for the fact that, like, don't be so scared of a term like annular tear that you sign yourself up for something very invasive out of fear. It's got to be, you're building an argument for what is really going on as a cause for your pain, and then trying to craft the smallest procedure possible, if at all, to get some relief from that.
So it goes back to, we talked about earlier in this episode, is that kind of detective work that you do of like, you look at it more of like, after I've already looked at you as a whole patient,
Yes.
what does this help tell me, but not let this be the whole story?
Yes, yes.
Okay.
Thank you so much for saying that too. You can meet a patient that has a very stiff hip to the point of the hip spine episode, or has poor biomechanics in the way that they stand and walk, maybe posterior chain muscle tightness. That can be the cause of back pain. The solutions for that is functional retraining and targeted physical therapy, identifying what a patient's healthy movement patterns are, what their unhealthy movement patterns are, what we call like spine hygiene, really, where you identify, okay, what are the movements that you are doing on a daily basis that are causing your pain? How can we avoid those, stick to safe movement patterns, and then slowly expand your repertoire of safe movement patterns so you can do the things you want to do and need to do in life, right? And that can often involve mobilizing your hip, getting your posterior chain musculature to be loosened up. A patient like that might have an annular tear, right? But that doesn't mean the annular tear has anything to do with their back pain. It could be a complete red herring. And that's why it's so important to start with the basics, talking to the patient, identifying what things are triggering their pain, what things are making the pain better, doing a thoughtful full body kinetic assessment, and then looking at the MRI. But if you start with the MRI and you say back pain, annular tear, must do something about annular tear, whether it's a fusion or anything else, that's not going to end well. And so that's where I think this sort of deductive reasoning, sort of thoughtful, stepwise approach is important for patients with back pain. And we always joke in our field, if you have a problem with your car, maybe it's just one problem. Like it's a funny sound. You take it to the mechanic. Oh yeah, there's something wrong with this component. We fix it. You're back to normal. With your back, it's not really like that. Your back is multifactorial. There could be multiple things going on. And so that's why this sort of comprehensive assessment is so important. And in the same way that, you would never try to figure out what's going on with your car by taking a picture of your car, right? You have to get your hands on it. You have to do a full assessment. In the same way, you can't really get a full picture of what's going on with the patient's back pain by just taking a picture of their back. That's just one piece of the puzzle. With that, I'll move on to the next image here. So another term that is commonly used in imaging is something called spondylolisthesis. This is a mouthful, okay? There's two terms we should probably clear up here. One is spondylosis, which is very commonly seen in imaging reports. The other one is spondylolisthesis. Spondylosis is basically a fancy word for arthritis, for abnormal bony degenerative changes and buildup that happens with wear and tear as we all age. So if you compare a given disc or a given facet joint in the spine from a 20-year-old to an 80-year-old, you're going to see a lot more spondylosis in the 80-year-old than the 20-year-old. We like to say it's like the gray hairs of the spine. So spondylosis in and of itself is not a disease. It's not something to like lose sleep over in and of itself. Now, are there situations where spondylosis is directly or indirectly leading to nerve pinching and a sciatic type pain? Sure. But people shouldn't go to bed at night fearful that, oh my gosh, I have spondylosis. That's just a part of natural aging and wear and tear. That sounds a lot like a different term, which is spondylolisthesis, which
Why
means...
are they making it so tricky for us?
I know,
like
right?
This,
it's almost like the legal world, where it's like, are they making these terms purposefully confusing, for job security? What's going on? But so spondylolisthesis is basically slipped vertebra, and you can see that here on this X-ray. This is what we call a lateral view, and so I'll outline here with the marker. This is the L5 vertebral body. And this is the L4 vertebral body. So this is an X-ray, not an MRI. But as you can see, the back of the L4 vertebral body square is in front of the back of the L5 vertebral body square. That is abnormal. Normally, we want those lines to be totally stacked up vertically and not to have this shift. That shift is called a spondylolisthesis. And in our world, we tend to differentiate these slips into one of two categories, either something that's fixed or something that's loose. And so some slips are sort of fixed in place in that way, in that configuration, so that if you stand, walk, bend, twist, that slip is going to stay where it is. If there's a 3 millimeter gap between L4 and L5, it stays at 3 millimeters no matter what you do. And then there are the patients where if you bend forward or you stand, that slip goes from 3 millimeters to 6 millimeters. And then when you sit back down or lie down, it goes back to 3 millimeters. That's called like a dynamic spondylolisthesis. And traditionally, it's the dynamic spondylolistheses that in patients with back pain and leg pain and corresponding MRI findings that often will get a fusion historically. Those are the patients that will be good candidates for something like MODIS, if and when hopefully it's approved soon. And there are patients that have the non-dynamic slip, so a fixed slip, who oftentimes can get away with just a decompression if they have mostly leg pain. And so if you have a spondylolisthesis, probably the single most important question you can ask your doctor or your surgeon is, can you tell me if my slip is dynamic or fixed? Because if it's fixed, then the next question is, are you sure I need to get a fusion? What about a decompression instead? It's at least a question worth having. There are situations where it's reasonable to do a fusion with a dynamic slip, with a fixed slip, but it's a conversation that's definitely worth having. And spondylolisthesis is a scary enough term, so hopefully this demystifies it a little bit.
And can you explain what a decompression is just for those listening as well?
Absolutely, yeah. So when you have shooting pain down your leg, if that is coming from a pinching of a nerve in your lumbar spine, whether due to a disc herniation, a bone spur, or slipped vertebra like a spondylolisthesis, what we mean by decompression is essentially taking the pressure off that nerve. And so we use a variety of tools to do that, whether it's small biting instruments or high-speed drill, either through an endoscope, down a tubular retractor or whatnot. But the whole idea of a decompression is to create breathing room for the nerve so it's no longer pinched and to not put any metal in the back. That's the idea of a decompression. So take something that's compressed and decompress it. And traditionally, the two options for surgeons when it comes to the lumbar spine has been decompression or fusion, one of the two. And that's why motion preserving strategy is so exciting, because it adds a third way.
When you're looking at this photo as well, so when you look at A and B, there's also a forward versus a backward slip. You want to talk about a retro versus an anterolisthesis here.
Yeah, great point. So as you might expect, so retrolisthesis means that the vertebra above is slipped behind the vertebra below it. Anterolisthesis means it's slipped forward relative to the vertebra below it. If it's dynamic, and again, which means that the amount of slippage changes as your body position changes, then those are patients that historically have been candidates for fusions, but maybe candidates for something like a motion preserving device now or in the future. And this is why, again, it's so important to talk to the patient, because if you have 90% of your problem being leg pain, and yeah, you have some back pain, but it's mainly just an annoyance, it's really your leg pain that's limiting you. Even if you have a slipped vertebra, spondylolisthesis, whether it's retro, antero, what have you, if it's primarily leg pain, you can often consider doing just a decompression for that patient, whether it's endoscopic, minimally invasive, or otherwise. And will it be the last procedure you get? Maybe, maybe not. But it's not right to basically say, oh, you have a spondylolisthesis, therefore you need a fusion operation. It's about the patient's primary complaint, how that complaint matches up with the imaging, and then what kind of activities they're wanting to get back to, and then crafting a plan that way. Some patients will say, hey, doc, whatever you do in there, I want to maximize a chance that this is the first and last spine surgery I ever have. If that's the case, maybe a very targeted, minimally invasive endoscopic decompression doesn't make sense, because we know there's a chance that the slip is still going to cause problems in the future. Those are the patients that have historically been candidates for fusion, and the future will be candidates for a motion preserving total joint replacement. But there are other patients that say, hey, if you can put a huge dent in my leg pain, I'll be great. And if I need to cross a different bridge when I get there 5 years, 10 years down the line, that's a success for me. Those patients can often get a minimally invasive decompression, even in the setting of this slipped vertebra or a spondylolisthesis. And that's why it goes going back to the theme of it's about the patient's symptoms, about their goals, and then using the imaging and everything else to confirm what's going on and then crafting a plan that's tailored to that patient. So having said that, we'll move on to the next one.
Can you just circle too so the patients can see on B as well?
Oh, yeah.
Where that one, I'm sure you can tell, but I think.
Yeah. So here, squares are a little off, but you can see that 5, 4. So the L2 vertebra is slightly shifted behind the L3 vertebra. That's called a retrolisthesis. So if you're talking to a surgeon and they're explaining, hey, you have a spondylolisthesis, therefore X, Y, and Z, the next thing that should be done is you should be getting dynamic x-rays of you sitting, standing, leaning forward, leaning back to understand whether this is mobile or not. Because even if a slip is mobile, if it's only 1 or 2 millimeters of a difference between, say, flexion and extension, you may not have to do a fusion in those cases. Even with the current offerings, you may be able to do a decompression. And so just going back to the point of more questions, the better when it comes to a conversation about a fusion operation.
Or potential one.
Yeah, potential one. So now...
This is a very different image.
Yeah. So going back to the beginning, there are 2 basic views that we use to look at the lumbar spine via an MRI, sagittal and an axial. The sagittal is that side view. The axial is the cross-section view. So these 3 images here are 3 different hypothetical patients, all on the axial view. Let's say this is the L4-5 level, okay? So the way to think about this, if you're in an office with your surgeon or your primary care doctor, is that imagine that you're lying on your back and your feet are coming out of the screen and you're looking up at the ceiling. That's the sort of body orientation that corresponds to an axial MRI. Because of that, the left side of the screen is actually the right side of the patient. And so that can get a little bit confusing. And so I'm just going to highlight some basic sort of building blocks of the anatomy here and then take you guys through a couple additional interesting terms. So in this view, this black circular item is the intervertebral disc or the vertebra. This right here is the spinous process, and it turns into, in this Y configuration, into the lamina. I'm going to make a triangle here. This area of white substance is the spinal canal. And if you can make out within there are some individual black dots. Those are actually the spinal nerves floating in the spinal canal. So if you can make out those individual dots, that means in general, there's enough space for those nerves to float. And the nerves essentially float in this water balloon. And the lining of that water balloon we call the dura, D-U-R-A. So if you can make out the individual dots, that gives you some clue that there's enough room for those nerves to breathe and your stenosis isn't that bad. And that brings us to probably the most commonly referred to term in MRI reports, which is stenosis. Stenosis is nothing more than narrowing around anything in the body, in this case, the nerves. So if you have mild stenosis, that means there's a little bit of narrowing, but not too bad. If you have severe stenosis, that means your nerves are really getting pinched, and that could be a source of some of your symptoms. What we see here on either side is what's called the facet joint that I've circled there. So the facet joints you have at each level of your spine on the left side and the right side, these sort of work on shear forces, and they provide stability and sort of control of the motion segment in addition to the intervertebral disc that's out front. So if you see in your MRI report something like severe facet arthritis or severe facet spondylosis, that's basically saying that those facet joints are very arthritic and that they become degenerated and they may not be serving their function quite normally. And so a facet joint can be a source of chronic back pain as well. Clues to that would be, like we talked about before, twisting motions, anything where you're extending your back, standing, making your pain worse, could suggest that the facet joint is one of the main culprits. And that's the kind of problem that could be amenable to that endoscopic medial branch transection, where once you identify that this really is the culprit, you can basically go in with a small camera and snip the nerve that creates sensation for that joint. So that's like a rough overview of what an axial MRI looks like. Perhaps the most useful thing to show on this slide is what mild stenosis versus severe stenosis looks like. So if you remember, I had drawn a triangle or sort of characterizing the spinal canal and the nerves floating inside. The middle figure is essentially a case of moderate stenosis. So I'm going to try and outline the spinal canal here. That's that triangle. And then over here, it's a much narrower space. So if you can imagine, in the small area that I've highlighted all the way to the right, that's where all the nerves are getting clumped together and squished, versus on the leftmost where you have a much larger triangle for those nerves to float in. So you have mild stenosis on the left, severe stenosis on the right. And patients like this on the right will often have what we term neurogenic claudication, which means if you're the type of patient that whenever you stand and try to walk for any extended period of time, your legs start giving out, you have pain in your buttocks. As soon as you sit down or lay down, the pain gets better. If you have what we call the shopping cart sign, where if you're at the grocery store and you lean forward on the shopping cart, suddenly your pain gets better and you feel relief. That's all a sign of neurogenic claudication from severe lumbar stenosis. And one reason I wanted to bring this up is that if you can imagine, what we do in traditional surgery is we take a trajectory like this down to the spine, and we basically want to remove a lot of this bone and ligament to create space for the nerves. And what patients will often be told is that in order to adequately decompress or free up the nerves in this case of severe stenosis, that the surgeon is going to have to remove so much of the bone, including those facet joints, that it might destabilize the spine, and therefore a fusion is necessary. And what one message I'd like to convey is that, yes, they may be true in certain situations, but there are plenty of patients out there, especially if you don't have that slipped vertebra or spondylolisthesis, where if you can go in minimally invasively or endoscopically, you can remove the pieces of anatomy that are putting pressure on the nerves without destabilizing the patient, and you don't necessarily need to do a fusion. And even if you are, as a surgeon, a little bit concerned that that destabilizing phenomenon could happen, it's still worth a conversation with the patient to say, hey, look, here are the odds where I think we can get this job done and not destabilize you. Would you like to do that versus doing the bigger operation and going straight to the fusion and getting on that train? And so before you sign up for a fusion surgery or any big surgery, you really want to get an understanding of why the fusion is being recommended. Like, what is it about your given situation that is making that seem necessary to that surgeon? And just because you have severe stenosis does not mean that you need an operation like that.
So as we talk about stenosis as well, stenosis is a giant general term, right? And so there's a lot of different, stenosis is the function of what happens because other things are breaking down, right?
Yes.
So can you talk about a couple of different reasons why stenosis would happen, right? So you can have disc degeneration that can cause stenosis. You can also have bone spurs or, facet arthropathy that's causing that. There's a lot of different causes of that. Could you talk through that a little bit?
Thanks for the question. In general, we talk about stenosis in three broad buckets. There's central stenosis. That's a classic example is the picture on the right, where all the nerves in the center of the spinal canal are getting compressed. And it's usually due to hypertrophy of the ligament that surrounds that canal and of those facet joints, and possibly a disc bulge as well. The other extreme is something called foraminal stenosis, which we'll show in the next slide. That's, if you imagine that the spinal canal is sort of like the interstate highway where all the cars are going up and down. And then every couple miles you have an exit ramp where individual cars can leave. That's kind of the way the highway of the nerves works in the lumbar spine, in that you have the central trunk of the spinal canal where most of the nerves run. And then at every level of the spine, you have certain nerves that exit. We literally call them the exiting nerves. And that exit ramp is the foramen. It's a window in the bone through which the nerve can exit. And if that nerve is getting pinched there on the side, we call that foraminal stenosis. And it can be from a disc bulge, it can be from arthritis, disc space collapse. And based on the reason for that stenosis and the nature of the pain, sometimes an endoscopic or a minimally invasive technique can be effective. The third one is called lateral recess or sometimes subarticular stenosis. That's sort of in between the central area and the foramen. And if you have sort of what we call sciatica, so you have this pain that's shooting down the outside of your right leg only on one side, it's a very clear distribution of pain. You could take a pen and you could literally trace on your leg where that pain is. That is often coming from either foraminal or lateral recess subarticular stenosis. Whereas if you have central stenosis, because so many nerves are getting pinched all at once, you instead have this generalized diffuse problem where your both legs are buckling, both of your buttocks are hurting whenever you stand and walk, and then everything gets better when you sit down. So that's kind of how we sort of pattern match the different types of stenosis with the actual symptoms that the patient has. So on the next slide to that question, we have a good example of foraminal stenosis. So if you remember, there's something called the sagittal view of the MRI or the side view. That's what we're looking at here. This is sort of not in the midline. This is a slice that is actually through the foramen. And I'll give you a sort of a quick run through of this. So here is the intervertebral disc between L3 and L4. Right here is a individual foramen. And then if you see, it kind of looks like an eyeball. There's a black center there. That's a cross section of the exiting nerve root inside the foramen. So if you see a black dot with a lot of white substance around it, that's normal fatty tissue around the nerve. That means that the nerve is healthy and not getting actively compressed. We can look at that in contrast to this foramen here, where you can make out that this disc has sort of pushed up into the foramen, and you don't see that nice white ring. All you see is blackness inside that foramen. That suggests that that nerve is not happy in the foramen, and that if this patient has signs of what we call an L4 radiculopathy or a pain that's shooting down the leg and the corresponding distribution, then we feel confident saying that this foramen is the cause of the pain. And there are a lot of surgeons out there that tend to say if you have foraminal stenosis, you need a fusion. But that's also not the case. Oftentimes, you can minimally invasively or endoscopically create breathing room for that nerve with a discectomy or some bony shaving and create some room for that nerve and then relieve some of your leg pain. So this is an example of foraminal stenosis from a disc herniation. And this is the last slide I have to show you guys. And so this is a situation that we encounter frequently. Say you've had a disc herniation. You tried everything short of surgery. It didn't help. Then you finally get a discectomy. You do great. You're back to living your life. And then say a year later, that same horrible pain comes back. So you may say you get a second discectomy, and then it comes back a third time. So you have a third time recurrent disc herniation, and now the surgeon is telling you you need a fusion because you just need to get rid of that entire disc, stop the motion at that level so you don't run into this problem again. This MRI is sort of emblematic of a situation like that. You can see on the left the arrow pointing to a big disc bulge, and on the right, you can see right here, this is the disc herniation on the left side because this is an axial view. And I just want to point out a few things to try and make an interesting point here. So if you look at this patient, the individual surgeries that they would have had in the past involve the surgeon making a corridor like this, the way the arrow is pointing, getting to this disc herniation in this manner and trying to pluck it out and moving the nerves off to the side to be able to remove that disc herniation. Every time you do that, there's natural scar tissue that forms. And this bone right here is part of the facet joint. Every time you have to come back, you have to remove more of that facet joint in order to get access to where the disc herniation is. That's what we mean by potentially destabilizing the patient, is that facet joint is there for a reason. And the more of that you remove, the higher the chance you're going to need a fusion. And if it's your third time considering surgery, that's when a fusion becomes oftentimes part of the conversation. What we can do with endoscopy in the transforaminal approach is actually come in a completely different trajectory, which is like this. And with a very small endoscope, we can come in from the side through the foramen to get to this disc herniation and not deal with any of the scar tissue that's here and not remove any of the structure, the portion of the facet joint that is required for structural integrity. And so it's basically a straight line attack right to where the disc herniation is, avoiding scar tissue, not having to move away and retract on a nerve, and not having to remove critical stabilizing bone. And so this is a kind of example of how endoscopy, when done thoughtfully, can be a motion-preserving strategy. Now, will this patient need a larger surgery in the future? Maybe, maybe not. But it's worth at least talking to your surgeon about whether something like this can be in the cards for you if you're in this kind of situation.
I think it's really important. I think we touched on a lot of topics. So there's a couple things I want to circle back on. Use the term hypertrophy. You see that a lot in radiology reports. Can you explain just what that is?
Yeah, no, thanks. So there's like a general sort of sequence of events that happens as your lumbar spine degenerates that I'll briefly touch on that captures this point. So what essentially happens is that you start out with a very plump, water-filled intervertebral disc, like a sponge that's just been soaked in water. Over time, that disc dries out and it essentially starts to flatten like a pancake. When that disc starts to flatten and degenerate, the other components of that segment of the spine start to overcompensate. So what do? If you can imagine the ligament in the backside of the spine as like a taut sheet that is providing stability for the spine, now when the vertebra above and below are starting to sink into each other, that taut sheet starts to buckle. And as it buckles, it starts to thicken in an abnormal way to sort of provide extra stability. That thickening of that ligament we call hypertrophy. And the facet joint can do the same thing. As it starts to degenerate, it wants to stabilize things. So it starts to grow extra abnormal bone, and it can also hypertrophy. So when the facet joint hypertrophies and the ligament hypertrophies, that combination can cause various types of stenosis, and it can cause pain in your legs, pain in your buttocks. But back to the point of words like hypertrophy in and of themselves are just a description of the degeneration that's happening. It doesn't necessarily mean it's a scary diagnosis that you have to lose sleep over.
Absolutely. I think that's such an important point. I'm looking at this last slide here. You look at the left side of the slide, and if you looked at this, you could say, "What? I need treatment at every level." Right? And I mean, truthfully, right?
Sure.
I mean, you would look at this and you could say there's a disc bulge at 4, 5, 3, 4, 2, 3, 1, what
Right.
we're looking at here. But to your point, that comes with confirmation of physical exams and everything else, because it can be scary when you look at this. And on this report, you're going to have disc degeneration. You're probably going to have degenerative disc disease, right? You're going to have disc bulges at 4 or 5 different levels, and someone saying, oh, I had some back pain,
Right.
and now what am I in for, right? But I think this is a great example of that you're not treating, and I'm not saying that's not the case, but you can get these where you're not treating everything that's on there. Correct?
Absolutely. It really gets back to this philosophy of what is the primary complaint? What are our top theories about where that pain is coming from? How do we match that up with the imaging? And then how do we tailor a treatment plan for that, starting with non-surgical, then moving into surgical? And one thing that I think can be enlightening for patients is to realize that when a radiologist is interpreting an MRI, it is their job to go level by level on the spine and identify and describe anything that looks different from a stone cold textbook normal MRI of an 18-year-old. So anything that's a deviation from that, they're going to report. It's just the nature of the sequence that they go through. So just because they report something as being different from the perfect spine of an 18-year-old doesn't mean it has anything to do with your symptoms. And you shouldn't, there are patients, especially as you get older, 60s, 70s, 80s, where there's going to be something to describe at every level. And if you're reading that and be like, oh my gosh, my whole spine is messed up from L1 down to S1. Now I'm going to need some huge operation. That is not necessarily the case, because I guarantee you there are going to be plenty of other people walking around that don't have any of your symptoms, that if we got an MRI of them, they would have many of these same findings. And that's why the imaging is just one additional tool in the sort of problem-solving process, putting the puzzle together to figure out what's going on with the patient.
Do you know what the data looks like on that in terms of asymptomatic patients that are walking around in the world? If you were to set them in a room and take imaging on them, who would have pathologic findings that may be asymptomatic?
It's a great question. I don't have the numbers off the top of my head, but it is something that we in the medical field we sort of call natural history, right? And it's sort of, and the phrase like captures that sentiment, right? Is that what is the natural evolution of the spine? If you were to take a patient from when they were 20, 30, 40, 50, 60, 70, 80, and say they never had a back problem a day in their life, that spine is going to change every decade. And you're going to find all sorts of new descriptions in the MRI report every decade. But that doesn't mean that has anything to do with the patient's symptoms. My guess is that probably for every one patient that has a disc bulge or an annular tear and has corresponding symptoms, there's probably 10 patients that have those identical findings and have no symptoms that are related whatsoever.
I think that's such a great point. I think as we talk about endoscopic care and we talk about motion preservation, and I think they go hand in hand, when the point that you just made, which is that your spine changes over time, you should have something that can compensate over time, right? Like you should have a mobile joint that can compensate over time, because if your spine is changing and what, if you want to call it your sagittal balance or your alignment, if you have mobile joints or motion preserving options or endoscopic care where you're preserving that tissue, your body essentially will find its new balance, right?
Yes,
and I think it's a really interesting topic as you bring it up that way.
I think it's great. You know, we've chatted about this before where there's a lot of energy and research work into finding out the perfect way to plan a fusion surgery to put the patient's spine in the appropriate alignment for the given age of a patient, right? It's like some of our best people are on it. They're on the case, right? But it begs a question, like, why do we have to work this hard to find the perfect angles and the perfect alignment for a fusion surgery at 1, 2, 3 or more levels? And does it mean that maybe the right solution is just to have a strategy that preserves the motion across that segment and reconstructs those 3 joints, the intervertebral disc and both facet joints, and then basically saying we're trusting that the body is smart enough to find its own home, right? And that you just have to give it the flexibility to do that, literally and metaphorically, to do that, and it will find its home. That's why we're also excited for motion preserving strategies like MODIS, because it just allows the body to do what's right at the right time, and that you don't have to really overthink it quite so much. You just let it do its thing.
It's a great sentiment.
It knows better than we do,
that's
right?
A great sentiment.
You know, that's the wild thing. And I think this also speaks to, we talk about this all the times, patients know more about themselves than what an image is going to show too. So it's so important. I think this is great information for patients, but also being your own advocate is so important. I love all of the, little nuggets you gave patients of ask these questions. Those are so helpful because you know your body best, you know how you move best. So you have to help fill in that story with your patient or with your surgeon and not let them just fill the whole story in for you.
Right. I'm so glad you brought that up. Maybe the final thing I'd like to mention is that, we're all very busy. Patients have work, families, surgeons are seeing 30, 40 patients in a day. You may only get 5, 10 real minutes with a surgeon when you do an initial consultation. And so the surgeons, myself included, we're trying to maximize that time, use that time to explain what's going on, what we think needs to happen. But, if you go back to sort of the original paragons of medicine and Western medicine, what they talk about is that there's a classic quiz that medical students are given in their first year of medical school. It's what's the most important part of a medical evaluation? And the options will be the history, the physical exam, imaging studies, so on and so forth. And first year medical students often answer with imaging. Well, of course, that's the latest technology. It's going to give you the answers immediately. And the teachers will say, no, wrong answer, try again. The next most common answer that medical students give is the physical exam, because it's like objective, right? You're going to find the truth when you actually put your hands on the patient. That's true. But the real answer is the history. And sometimes in the hustle and bustle of taking care of patients, it's hard to do that well. And so if you're a patient, I think to your point, the best thing you can do to advocate for yourself is to try and create that opening to really tell your story and talk about what patterns of behavior are making things worse, what patterns are making things better, what are your goals, what are you trying to get back to, what trade-offs are you willing to make? It's really about listening and speaking and meeting patients where they are, and the physical exam and the imaging all come later. And so it's hard as surgeons to do that, but that's something that as patients, the more you can have that experience with a surgeon or any type of doctor, I think the higher the chance that you're going to get routed to the solution that's right for you.
I think it's a great topic. And I think, that brings up the concept of specificity, right? To patient treatment, to getting the right treatment. If you go back to 2 slides ago here, that one. So we've talked a lot here as well. And I'd like you to bring this up. I'm seeing a lot of posterior pathology, what we'd like to call posterior pathology in the back. And so as patients go and find the right treatment option, I'd like you to talk about the concept that you have to find the right treatment option that's right for you, right? Every treatment option is not right for everybody. It depends on your pathology. So if you have posterior pathology versus a purely disc-based pathology, your treatment might be different. Can you talk about that?
Yeah, thanks for bringing that up. So the context for this, and I think why it's relevant, is that when patients have been considering surgery for their low back and they're looking for an alternative to a fusion, the historical alternative has been a lumbar disc replacement. And it's a great surgery for the right indications, especially when it's done by surgeons that are expert in them. The sort of classic sort of criticism of lumbar disc replacement is that it only addresses problems that stem from the disc itself. And as we've talked about here, all these components of the spine are linked. So when the disc starts to degenerate, it's very soon after that the facets are going to start to degenerate, that the ligament is going to start to thicken and hypertrophy, that you're going to develop some stenosis as well. And if you do get a lumbar disc replacement, you will have addressed the portion of your problem that's coming from the intervertebral disc, but you may have done little to nothing about the other components of that motion segment that are also degenerated and could be contributing. And so the power of approaching the spine posteriorly, specifically for motion preservation, is that you can address all the components that could be contributing to the pain at once. If the facet joints are contributing to back pain and stenosis, if the ligament hypertrophy is contributing to nerve pinching, you can address all those components and replace the intervertebral disc with a motion preserving implant all in one go. And so that's why a posterior approach for motion preservation is particularly powerful, is because if you know that the entire spinal motion segment is problematic, you can have a definitive solution and not sort of pick the component that you can get access to anteriorly through the belly and then sort of cross your fingers and hope that the other parts of the spine just sort of are okay.
I think it's a really important point because obviously we're going in there to treat the pathology, but you also have to restore function to the places that you're restoring some of that pathology, right?
Yes.
And so I think it's a really interesting point, and I wanted to make it. As we wrap this up, I think one thing that I want to say, and I know you're of the same portion, that this is not a substitute for getting your imaging read or things of that nature, right?
Yeah.
This is supposed to be a baseline so that you can start to wrap your head around what you're looking for and the questions that you should ask when these radiology reports come back to you.
Thanks for mentioning that.
This is not medical advice.
This is not medical advice. What we're hoping here is to provide a little bit of a vocabulary and a framework so that you can make a little bit of sense of some of the terminologies. But what you, of course, really need to do is talk to your primary care doctor, talk to your spine specialist expert, talk to your surgeon about your particular situation, because every situation is different. The other thing I'll say is that most surgeons pride themselves on reading their own MRIs. And so one easy way to tell that a surgeon is very thoughtful is that, they'll see the report, but they want to make their own determinations. They want to watch the movie themselves and then tell you what their interpretation is. And that's someone that's not just sort of taking information secondhand from somebody else, but really doing their own evaluation and then matching it to your story, your symptoms, your physical exam to come up with a treatment plan.
Well, we resonate with everything that you're talking about. We get so excited about it. So we appreciate, we know we've already taken your time once, so we appreciate you allowing us to come down here, visit you again, see the transition from TJU down to Naples and hear about your practice. I mean, it's incredible, everything that you're building here. And again, we just appreciate all your time. We appreciate you pushing education and doing everything that you do for the spine community.
And for those patients that are here and listening and saying, I want to see Dr. Siva, tell us a little bit about your practice and where they can find you.
Absolutely. So thanks for the question. Thanks for the opportunity to talk about these issues and get the message out to patients. So the program I'm part of right now is called HSS at NCH, Hospital for Special Surgery at Naples Comprehensive Health. And so we'll provide the phone number that you can reach to get a hold of us. Happy to see any patient either here in Southwest Florida or in the broader United States that feels like they've run into a brick wall, run out of options, and just wants to get a fresh perspective on their, chronic low back pain and see if we can provide some insight and some help and direction.
Awesome.
That's incredible. We'll include the phone number. We'll include the email, but I want to reiterate for people that aren't following you on LinkedIn, absolutely follow you on LinkedIn just to
Another
be able to,
follow.
be able to absorb all the information, everything. I mean, you share cases, you share lots of information. So we appreciate it. And we'll be here with you again soon. So thanks so much,
It's always
Dr.
an
Siva.
honor.
Oh, no, it's a privilege.
Thanks, Dr.
Thanks,
Sivaganesan.
Siva.
Thank you.